Hi, this is Dr. Cassidy here to talk about nutrition. First, I want to let you know that the content for the exam will come from the Lewis reading and my lecture. I've also included sections from the ATI nutrition book in the student prep that align with my lecture because I really like the ATI books. They're so condensed and concise, but I think there's maybe more information than necessary in the ATI book for this module. So that's why I'm sticking with the Lewis book and lecture for the exam content. I do want you to read the ATI content because the way it's organized helps understanding. And there are also quizzes in the student prep that will help you understand the content more, but again, may ask questions beyond what we're covering here, which is good. It will only help you understand the body's needs more, but I don't want you to get caught up in trying to memorize everything in ATI and the quizzes. Focus on Lewis and my lecture. Also, I created a version of this PowerPoint slide for you to print to take notes along with the lecture. It has blank spaces for you to fill in important words or concepts as we move through the lecture, which increases your activity in the lecture, so also increases your learning. Let me know if you find it helpful. Okay, let's get into it. Nutrition. First, we're going to do a quick review of what our bodies do with food. It may seem unnecessary, but trust me, if you understand these few things, it will help you understand different diagnoses and labs related to them in future content. And it's so important that it may be on the exam. Digestion is the process of breaking down food and excreting it through the GI tract. So chewing first breaks it down, and then enzymes in your stomach and GI tract further break down food and change it into forms that can be used by cells. The stuff the body can't use forms in the stool and is excreted in bowel movements. That's digestion. The stuff the body can use gets metabolized. And metabolism is the process of your body using food to sustain life. It does this through chemical reactions, and those reactions create leftover byproducts, also called waste products. Byproducts of metabolism are things the body can't use, and in fact will cause harm if they build up. Byproducts are removed from the body in urine, stool, and exhaled air. Macronutrients include carbohydrates, fats, and proteins. In digestion, carbohydrates are broken down into glucose by amylase and some other enzymes. Glucose is the main energy source for the body. Another important fact is that the body uses oxygen to metabolize glucose. The byproducts of carbohydrate metabolism are carbon dioxide, CO2, and water. Water the body can use, but carbon dioxide the body cannot use, so it's removed from the body in the lungs. And you remember from the lecture on acid-base balance that if CO2 builds up, the person goes into respiratory acidosis. Another thing is that when the body doesn't have enough oxygen getting to the cells, it uses anaerobic metabolism. That's metabolism without oxygen. Remember, aerobic is with oxygen and anaerobic is without oxygen. And the byproduct of anaerobic metabolism is lactic acid. This can happen when people are pretty sick, like in sepsis, and you'll see them draw lactic labs and they'll be elevated. That means that some tissue isn't getting enough oxygen, so it's using anaerobic metabolism. It's a sign that the person is pretty sick. Lipids, or fats, are broken down into fatty acids by lipase during digestion. Fatty acids are used as high energy sources. Remember, glucose is the main energy source. Fats broken down are high energy sources. The byproducts of fat metabolism are also CO2 and water, just like carbohydrates. And CO2 is removed from the body in exhalation phase of breathing. So usually our body uses glucose for energy, but when there isn't enough, it breaks down fat into ketones to use as that high energy source. This occurs during starvation or during the keto diet when people stop eating carbs. So if you're not eating enough carbs, then you won't have glucose. This also occurs when you do not have enough, this also occurs when you do have enough glucose, but you don't have enough or any insulin to get the glucose into the cells to be metabolized. So the body starts to break down fat to use ketones for energy. You see this in diabetic ketoacidosis, DKA. Ketones are acidic, and DKA is one cause of metabolic acidosis. The pH gets lower because the blood is acidic from the ketones, and the bicarbs get lower in the blood because it's acutely being used up to try to neutralize the ketones, so the bicarb is low, acidic. Eventually, the kidneys will secrete more bicarb, and of course, your respirations will increase as a way to get rid of CO2, which is an acid. Okay, I'm getting off track, but I just want you to understand how nutrition is connected to all of your other content. During digestion, proteins are broken down by protease into peptides and amino acids. What's important to understand is what proteins do. Proteins are used for growth and tissue repair. Byproducts of protein metabolism are ammonia, urea, and creatinine. Urea and creatinine are filtered into urine by the kidneys for excretion from the body, and ammonia is filtered or processed by the liver into stool for excretion from the body. Now, when a patient has kidney damage, they can't excrete as much creatinine or urea, so the labs will show elevated BUN, which is your blood urea nitrogen, and creatinine. Ammonia builds up when the liver can't process it out and into the stool for excretion. So when you have liver damage, you have a buildup of the byproduct ammonia. Sorry, I'm jumping back. I forgot to mention on the slide for carbs that the picture on the top are healthy carbs and the one on the bottom are unhealthy carbs. And the same for fat. The image on the top are healthy fats and the one on the bottom are unhealthy fats. And for proteins, we have them broken up into plant-based proteins or animal-based proteins. Okay, please don't get too deep into the slide if it makes you anxious. This is how I was able to understand nitrogen balance, so I'm going to go through it. But really, all you need to know if you're going to memorize is that negative nitrogen balance means the patient isn't getting enough protein, so they're becoming malnourished and losing muscle. This is super important to understand because patients need more calories and more protein when they're sick, even though they probably don't feel like eating. We as nurses have to ensure they're getting the nutrients they need, or it will take them longer to heal. Okay, catabolism is the breakdown of protein, and anabolism is the synthesis of protein. Normally, anabolism equals catabolism. That's a neutral nitrogen balance. When children go through growth spurts or during pregnancy, when the mom has grown an entire child, there is far more synthesis of proteins building that muscle and tissue than there is breakdown of proteins. That's a positive nitrogen balance. You can remember it that they are positively growing. The one we're worried about, especially in acute care, is negative nitrogen balance. That's when there is more protein breakdown, catabolism, than protein buildup, anabolism. That's a problem because it causes cachexia, which is severe weight loss and muscle wasting during serious illness when protein and calorie needs aren't met. Again, our body needs more protein and more calories in order to heal. Without it, healing is delayed. Patients stay sicker for longer, have more complications, lose function, and are at higher risk for poor outcomes. In other words, the food your patient eats is one of the most important pieces of their healing when they're in the hospital. And if you don't know that as a nurse, if you let them sleep through meals, if you don't educate and support patients to get the nutrients they need, then the patient will be harmed. Yes, patients have a right to eat what they want. But just like if they decline to take their antibiotics or IV Lasix, you would educate them why they need it. And if they still decline, you would inform the provider so that they could talk to them. As nurses, it's our responsibility to have that much diligence around their diet. Inform the provider so they can also educate the patient. Also, you can ask the provider for a nutrition consult so they will do a deeper dive into their specific nutrition needs and how to get them met. Okay, so maybe not if your patient isn't eating enough for like 1 day or 2 days, or if it's a young patient, young healthy patient. It depends on the patient, but please don't neglect this part of your patient's care. Micronutrients are vitamins and minerals. Vitamins can be water soluble or fat soluble. Fat soluble vitamins are stored in the body in the liver or fatty tissue, so it can build up and cause toxicity. Minerals regulate body fluids and other functions, and electrolytes are minerals with an electric charge. Nutrient needs across the lifespan. Excuse me. If you've printed the student printable PowerPoint slide, then please know that everything that you have to write down in the next few slides, the ones about pediatrics, are the things I think are important for you to know. The other things are nice to know, and you may need to know them for your NCLEX, but you'll do an NCLEX review course before taking it so they can help you hone in on what you need to know for that. For my pediatric exam questions, you need to know only the things that you have to write in the blank space. Infants should drink breast milk or formula for the first year. Do not use extra water to dilute formula or any liquid. Sometimes people try to stretch out formula by adding extra fluid, but then the baby isn't getting their nutritional needs met, which can cause growth and developmental delays. No honey or cow milk for the first year. Toddlers at age 1, it's okay to offer cow milk. It's also okay to continue breast milk instead or with cow milk. Aged 1 to 2 years, use whole milk because they need the extra fat. At age 2, switch to 2% milk to reduce fat intake. Also, milk has a lot of sugar, so too much will cause obesity, as will fruit juice. School-age children and adolescents' needs are listed here. Pause the video and read these slides. Okay, that's the end of pediatrics. We'll skip adults since we focus on them in relation to diagnosis, but I want to go over the specifics to older adults. They have decreased caloric needs due to decreased basal metabolic rate. They have decreased taste and appetite, decreased thirst regulation, and decreased gastric emptying. That, plus the possibility of decreasing fluid intake because they don't feel thirsty, makes them prone to constipation. So we should educate them to eat small, frequent meals to maintain adequate calories. This also helps with the issue of decreased taste and appetite because it's easier to make yourself eat a small meal. Also tell them not to fill up on drinks and save their appetite for nutrient-rich foods. If they are not thirsty and not drinking enough, they can schedule water intake throughout the day. Also, older adults should increase their fiber intake to help prevent constipation. An acute care assessment of patients should include a nutritional assessment. Is their weight normal for their height? That's the BMI, body mass index. A BMI of 25 to 29.9 is considered overweight, and a BMI over 30 is considered obese. That's important to know because once a person is obese, their body is working against them, and they are at increased risk for many diagnoses and complications. Things to include in the patient's assessment are any recent changes in weight, and then, of course, if it was intentional weight change or unintentional. If a person loses a lot of weight unintentionally, that's a red flag for cancer because cancer cells use a lot of energy, so use the calories the person is eating. Any difficulty swallowing or eating, so the diet can be adjusted to accommodate. Needs for any adaptive equipment to eat, especially utensils or cups that a person may need so they can hold them, or specific setups for a patient who are visually impaired. Or any type of assistance that they need with eating, such as opening containers or maybe even feeding them. If your patient needs to be fed, work with the CNA or PCA to schedule who's feeding the patient which meals throughout the day. You can also try to encourage the family to be present for mealtime and have them feed the patient. Whatever the plan is, do not let your patient go unfed. They need the nutrients to heal, and if you don't make sure that they're being fed, then harm is being done to them. I cannot stress enough how important food is to life. Okay, physical exam findings associated with malnutrition are listed on this slide. You should be aware of these. Labs associated with nutrition are also listed. The important ones in acute care are prealbumin, albumin, and total protein. Prealbumin has a short half-life, just a couple of days. So if that's if that's low, it means the patient is having decreased protein malnutrition currently. Albumin has a longer half-life, 20 days. So if that's low, the patient has ongoing malnutrition. Total protein is another lab providers would look at to see if the patient is malnourished. Look at the difference between these two pictures. One of them promotes healing, and the other actually promotes illness. When a meal tray is delivered to the patient's room, the best setup is to have the patient up in the chair. But if the patient is on bed rest or can't get out of bed or is declining to get out of bed, have them sit up as high as they can and set up the table for mealtime. This means removing urinals and bedpans and other unnecessary things to make room for the tray. Although, don't ever take away their incentive spirometer. Also, probably leave their tissue and water and anything else that they request. Have the food uncovered, drinks open, and things set up in a position that invites eating. They don't feel good, so may not want to eat. So it's even more important to set up a pleasant environment to encourage eating. And this includes brushing their teeth beforehand. This slide lists nursing interventions for different barriers to eating. Please pause the video and make sure that you know these. This slide is a list of different religions and some of their practices surrounding food. I'm not going to test on specific things. I just want you to be aware that people have different reasons for eating the foods they do. I imagine not everyone who is Catholic doesn't eat meat on Fridays during Lent, and maybe some Buddhists drink coffee. We shouldn't assume, and really the only way to know is to ask the patient if they have any food preferences or practices they follow. This slide lists other differences in dietary preferences or practices. One reason is not more valid or more important than another. It's really just that everybody gets to make their own choices about what they eat, and we as nurses should find out what those are and respect them. I'm going to go over some nutrient needs by diagnosis. When you get to the learning about the diagnosis, you'll go over these again. Here, I want you to have a foundation of understanding, so there may be a little more information than you feel you need under some slides. So I'll tell you specifically what you should know, so please pay close attention for this section. Diets that support cardiac health are low sodium, low saturated fats, low trans fats, and low added sugar. Patients should follow the Mediterranean or DASH diet. DASH stands for Dietary Approaches to Stop Hypertension. Also remember that some medications can put people at risk for hyperkalemia. ACE inhibitors, ARBs, and potassium sparing diuretics are a few. So patients should not eat a high potassium diet. Renal disease. AKI is acute kidney injury. Now, you already know that the protein metabolism byproducts are creatinine and urea, and that the kidney filters them out into urine for excretion. If the kidneys aren't working, they can't filter them out as effectively. So when a person has AKI, they may need to be on a low protein diet. This reduces the workload of the kidneys while they heal. Also, low phosphorus, low potassium, and low sodium for the same reason. The injured kidney can't filter them out. For CKD, chronic kidney disease, they are also on low protein and low phosphorus, low sodium, low potassium, and sometimes a fluid restriction. Once the patient starts dialysis, they can eat more protein because the creatinine and urea will be dialyzed out on scheduled days. Nephrolithiasis is a fancy name for kidney stones. These patients should have increased fluid to help prevent kidney stones from forming. There are also specific food avoidance based on the type of kidney stone. I felt compelled to make you aware that there are different types, but I won't ask on the exam about the different types or the foods. This slide covers hepatobiliary diagnosis. That's the liver, pancreas, gallbladder, and biliary ducts, which carry the bile. And bile is used as part of digestion to break down fat. Cirrhosis of the liver is when the cells become fibrotic, so no longer function. Remember, one of the functions of the liver was to filter out ammonia, the other byproduct of protein metabolism, into stool for excretion. If the liver isn't functioning as well, then the ammonia builds up in the blood. So we give the patients lactulose to promote extra bowel movements to get the extra ammonia out. Cholelithiasis are gallstones. Remember, nephrolithiasis are kidney stones, and cholelithiasis are gallbladder stones. All right, the prefix chole refers specifically to the gallbladder, nephro to the kidneys, chole to the gallbladder. Lithiasis is a stone. Now, cholecystitis is inflammation of the gallbladder, and you probably know by now the suffix itis refers to inflammation or infection. The diet for both cholelithiasis and cholecystitis is a decreased fats, specifically saturated fats, and to eat small, frequent meals. The gallbladder stores bile, and it contracts to release bile when it senses fat in the GI tract. When a biliary duct is blocked with a gallstone, it keeps contracting, trying to get that bile out, and that's pretty painful. So low fat means less gallbladder activation, and small frequent meals means the gallbladder will work less as hard, but more frequently to reduce stone formation. If a patient has cholecystitis, they will probably need antibiotics, and they may also need a cholecystectomy, which is just ectomy of the gallbladder. Once the gallbladder is removed, the patient may need to follow a low-fat diet for a few weeks, but then they advance back to a regular diet. The body still makes bile to digest the fat. It just can't store bile anymore without the gallbladder. Pancreatitis is inflammation of the pancreas. The pancreas, among other things that it does, releases enzymes for digestion. Amylase to digest carbohydrates and lipase to help with fat digestion. When the pancreas is inflamed, these enzymes leak out and start to digest the pancreas, which, as you can imagine, is pretty painful. It's called autodigestion. So these patients with acute pancreatitis are made NPO, no eating, because it's going to cause the body to digest the pancreas. And you'll see in the hospital, if they check the amylase and lipase blood levels, and if the patient has pancreatitis, those levels will be elevated. GERD is gastroesophageal reflux disease. It's acid from the stomach coming back up into the esophagus. These patients should avoid alcohol, chocolate, and caffeine, and other foods that trigger GERD. Also, avoid lying down flat for 3 hours after eating, so food has time to pass into the small intestine, so it won't reflux back into the esophagus. Celiac disease is a true allergy to gluten, so these patients need to avoid wheat products and other grains with gluten in them. The difference between inflammatory bowel disease, IBD, and irritable bowel syndrome, IBS. Well, there are a lot of differences, but for now, for nutrition, I want you to understand that the diseases associated with IBD cause diarrhea, and IBS can cause either diarrhea or constipation or both. So for IBD, which is Crohn's disease and ulcerative colitis, we will recommend a low fiber diet because they are stooling too much, so don't need fiber. Patients with IBS may benefit from a high fiber diet to regulate their stools. When patients have diarrhea, a bland diet is recommended, and when patients have constipation, increase dietary fiber to increase stooling. Patients with respiratory diagnosis will have increased work of breathing. They may also be fighting infection. These patients have increased caloric needs and increased protein needs. Also, increased fluid to thin secretions. Offer small, frequent meals because they won't be able to eat a lot in one sitting while they're using all their energy to breathe. Post-op patients also need more protein for healing. Specific to bariatric surgery is a need for vitamin B supplements. Remember, intrinsic factor is needed for the body to absorb B12, and intrinsic factor comes from the stomach mucosa. So if part of the stomach is removed, there's less intrinsic factor. These patients need to take extra B12 to give the body more opportunity to absorb more. Other diagnoses include burns, trauma, sepsis, serious illness, cancer, AIDS. What they all have in common is that patients with these diagnoses are at high risk for protein malnutrition. Alcoholism also causes protein malnutrition as well as vitamin B deficiencies. Wernicke-Korsakoff is alcohol-related dementia from B1 deficiency. Gout is a buildup of uric acid in the joint, frequently the big toe. When a patient has gout, they should avoid foods high in purines, such as red meat, alcohol, and shellfish. They should also avoid high fructose corn syrup. Oddly, increase in caffeine helps with gout, as does increase in vitamin C and water. Whatever your patient's diet's needs are, it's important to not only educate them about it, but also print the education. Whatever hospital you're at, they have a way to print patient education. So make sure that you do that because it's very hard to remember what someone tells you once or even twice, especially when you're not feeling well. Now, getting into more serious patient education and support around nutrition. We all know it's challenging to change our diet habits. Multiple studies show just reading the nutrition facts label improves food choices. Just the awareness makes someone much more likely to choose healthier foods. So teaching your patients that will work to improve long-term health. And I tell patients to just start at home. Read the nutrition facts label of food you already have in your cabinet, refrigerator, and freezer. And start with one nutrient to not overwhelm them. So for a patient who would benefit from a 2,000 milligram sodium diet, have them just look at sodium. Okay, but honestly, it's going to be hard for them to count up all the milligrams of sodium that they eat throughout the day. An easier way is to use the 5%, 20% rule. Any nutrient that you want to eat less of, choose foods that contain 5% or less of the percent daily value. And nutrients you want to eat more of, choose foods that contain 20% or more of the percent daily value. For patients trying to reduce sodium intake, Warn them that maybe a lot of the food that they have at home is high in sodium. Encourage them to make choices about ones that they can swap out for lower sodium choices. They'll see when they look in their salad dressing and ketchup and canned soup and frozen meals and any processed food that there are plenty of places to reduce sodium, and they can make choices that work for them. We just want them making informed choices, and reading the nutrition facts label makes them informed. You can print the slide out and educate patients with it. I have a similar form that I've created that I use for patient education. This is a list of food medication interactions. I don't expect you to memorize these. Please do not. I'm going to go over them so you have a basic understanding. Grapefruit juice interferes with many medications, and it can either make the med not work or make the med remain in your blood longer, causing toxicity. Alcohol interferes with many meds as well and can increase the risk for sedation and bleeding. Those are the big ones. Disulfiram is antabuse. It's an old drug to help with alcoholism. It makes you throw up if you drink alcohol. If a medication has that alcohol causes a disulfiram-like reaction as a side effect, that's all it means. You don't have to know that, but I've seen it as a side effect for many drugs, so I'm explaining it. You do want to know that vitamin K is the actual antidote for warfarin. It makes it not effective. So people on warfarin need to avoid or eat consistent amounts of foods high in vitamin K. People at high risk for hyperkalemia should limit potassium. So taking ACE inhibitors, ARBs, and potassium-sparing diuretics will put someone at high risk for hyperkalemia. Protein and dairy can interfere with absorption of some meds. This is a good slide. Be aware that all of these foods types cause inflammation. You don't have to memorize the diseases, but you should know the foods, and then you can educate your patients. The rest of these slides are not for you to memorize. They're just information to read once to increase understanding. So pause the video at each slide, read it once, and move on. This slide is just a food description key in case someone doesn't know what foods are considered dairy or red meat or whole grains, etc. Okay, these are my references. Please let me know if you have any questions.